Bore da I chi gyd, a croeso I Bwrdd Iechyd y Prifysgol Aneurin Bevan. Welcome to our Health Board meeting. As you are aware, this meeting is being held via Microsoft Teams and will be live streamed via YouTube and other social media platforms. So I don't know who will be in the public gallery, but I'm very pleased to welcome Angela Mutlow, whom I know is here. I don't know if Gabby from Audit Wales is here as well.
Gabby decided to watch it via YouTube. She just emailed me a moment ago, Chair. Thank you.
Thank you. Thank you. Well, welcome via YouTube then, Gabby. Technology will work. But if you feel that you're dropping out a lot, then please get hold of Lucy and she will make the arrangements for you to call in instead. If people could keep on mute unless they're speaking, it would be helpful, please. And it will be helpful if the executives could announce who's actually in the room, because it's not possible to see who's in the room because you're all so far away. So could we take a roll call of the executives, please?
Judith Paget, Chief Executive.
Nicola Brigodic, Director of Planning.
Nick Wood, Director of Primary Care, Communities and Mental Health.
Mary Bovey, Director of Public Health. Sarah Aiken, Interim Medical Director.
Glyn Jones, Director of Finance and Performance.
Rhiannon Jones, Director of Nursing.
Thank you. Thank you, that's most helpful. Thank you. Now, apologies for absence. I've had one from David Jones. Is anybody else aware of any other absences that haven't been notified?
Chair, Louise Taylor, who is the chair of the Healthcare Professionals Forum, has given her standing apologies during the period of the pandemic as she's focusing on operational activity, but hope to rejoin us later in the year.
Thank you. That's helpful. Are there any declarations of interest of any of the issues on the agenda today? No? Okay. Can we move then to the draft minutes? Firstly, of the 20th of May. Are there any amendments to these minutes? Richard, have you been notified?
I haven't, Chair. No further notification of any changes following their issue. No. Okay.
Are we happy to accept this as a correct record? Thank you very much. The minutes of the 25th of June, are they a correct record? Yeah, okay. And lastly, 30th of June, are they a correct record? Okay, well, thank you very much. I accept those three sets of minutes. If I will ask whether anybody has anything that they wish to raise on the three sets of minutes after we've gone through the action log. If they haven't been picked up there, is that all right? Are you happy to do that? Thank you. So the action log, Richard.
Thank you, Chair. These pick up the actions from the minutes between the 20th of May and the 30th of June. Each of the items have an update against them or outcome in relation to the actions agreed by the board. Many are complete or in train, and where there are ongoing matters, they have been identified in terms of the progress updates. So there was nothing particularly, Chair, that I wanted to flag at this stage, other than if there were obviously questions from members in terms of the current status of each of the actions, but we're confident that everything is planned into our programmes of work or progress is being made as planned.
Thank you. Are there any questions arising from the action log that members would like to ask?
Chair, it's Shelley here.
Shelley.
It's just on the first action. I'd raised the question, the staff welfare support obviously is fantastic and we've got a lot of good stuff going on. I was just interested to know how many people are actually taking advantage of that. So that was what the question was. Whilst the update says we have been provided with information, which I agree, I think it would be helpful just to have an overall feeling about how, how staff are reacting and what the uptake of those, a number of the services are.
Yeah, can I respond? can I respond to that, please?
Yes, please.
So, yes, we are recording the data, Shelley. I think what we're seeing is that referrals to our employee wellbeing service are steadily increasing, and that follows a sort of a slowdown during the pandemic, but as anticipated, it is increasing now following the first phase. But I can provide data, Chair, if you want, in relation to the number of referrals.
Thank you.
And the support that we're providing.
Yeah.
Chair, could I just have have one follow-up? I mean, I think what I'd be interested in, are there areas where we know that people were right in the front line, and are those people now referring themselves for support? So I think it would be just, that's what I'm looking at, Garrett, is, are there areas where we would expect there to be people coming forward now, but perhaps are not? Or, vice versa, or people that perhaps were in what I would term back office services, people working at home who found it particularly difficult, who may be now moving back into offices. That was the sort of the background I was looking for, really.
Yeah. So we can provide that, Chair, that analysis, but I think generally the picture is that people are now using the service more as we come out of that first phase of the pandemic. So it's and we anticipated that from day one, really, that things would increase following that initial response. But I can certainly provide that data, Chair.
Yes, a very short paper on that would be very useful to inform the board. And I'm very pleased that we have the staff's confidence in our support scheme and that they are using it because it's vitally important to them and their future well-being. Thank you.
Anne, could we add on come in, please?
Yes, certainly.
Thank you. Thanks, Julia. Thanks, Chair. I thought it would probably just be helpful to mention the staff survey as well, Geraint. We had a presentation at the executive team earlier this week, Monday, and they were really positive results in terms of the psychology and psychological support that staff have been receiving, with some areas of 10% of respondents which identified areas that we could do some additional work. And a number of those people were some of the individuals that have been shielding. So we're looking at the actions that we can take to improve the provision of support for those individuals going forward. But it would be important to note that of the responses, 90% of staff were extremely positive about the support and the experience through the pandemic.
Thank you, Rhiannon. That's really, really encouraging. And so perhaps, Geraint, if you could include a short overview of the highlight of the report that you've now received on the staff survey, that also would be useful. Louise?
Yes, can I ask a question on, now that staff that within the wellbeing service that we've that have been working there and now going back to their substantive posts, how are we going to maintain the balance now that there seems to be a demand for staff using the wellbeing services?
So if I can respond, Chair, so what we're looking to do is to strengthen the service by actually recruiting some additional psychologist support. We're in the process of exec team are actually in the process of looking at that. So that will strengthen, that won't replace the number of staff that we did deploy during the pandemic, but it will certainly help strengthen the service. And then I think it's about realigning our wellbeing services so that we address the specific issues that we know are emerging from the first phase. So it is about strengthening what we've got already and also trying to redirect those resources to where they're needed most.
Yeah. Thank you, Geraint. Anything else arising on the 20th of May minutes that anybody would wish to raise that hasn't been picked up? No. 25th of June? No. 30th. Richard, we've had a couple of queries from David Jones. Would you like to take us through them, please?
Yes, certainly, Chair. I'll just get that appropriate page up of my notes. The questions from David in relation to the minutes themselves relate to, just getting to the page, Chair. It was queries really in relation to minute of the 30th of June, page 5, page 22 of our admin control book, in terms of his question and how assured we could be that the service redesign work for clinical futures, which until the most recent RAG rating was shown as red, could be completed in time for the planned early opening of the Grange University Hospital. And I don't know if Nicola is in a position to provide any update on that for us.
Yeah, thanks, Richard. Yeah, so obviously as part of the work we shared at the board meeting and subsequently at the Planning Strategic Change Committee, all of the services have been through a readiness assessment in preparation for the Grange to ensure that the models are fit for purpose in terms of moving in, whether they're part of that November opening or whether they would feature more in the kind of post-March 21. And a number of key issues or risks that have been identified have been picked up and are being worked through to ensure we can mitigate, but the majority of services and those models are confirmed and are in a position to proceed into the Grange as planned.
Thank you. Thank you, Nicola.
There was one further, sorry, Chair. There was one further point from David in relation to page 3 of the minutes of the 30th and page 20 of board books in relation to the comments around the use of AI, artificial intelligence and radiology, and the recruitment of 11 new radiologists. And he just wondered if there was any further update in relation to that area.
And thanks, Richard. And I dealt with a number of email queries from Shelley as well regarding this issue since the last board meeting, which I've done some further follow-up work on. So obviously we continue in radiology in particular, we continue to look into the opportunities that artificial intelligence can bring us, but there's no kind of accredited, approved system that is in use at this point that we are not taking advantage of. And therefore, until that time, we wouldn't be using it. But we obviously are involved and stay close to any developments that are happening across the country and worldwide in this area.
Okay, thank you.
Thank you, Chair.
Paul, you had a question.
In relation to the minutes or later?
You're going to raise it later?
Yes, I've got some questions on the Grange Hospital and one on the reconnection of services. Do you want me to ask them now or later?
Later then, please.
Okay, that's fine.
Thank you very much.
Happy with the minutes.
Thank you. Can we move then to the governance matters and sealed documents and chair's actions? And Richard, can you take us through these, please?
Thank you, Chair. Yes, this is the procedural report that you receive at the board at each meeting, and the board presents the Chair's actions that have been undertaken in line with standing orders between the 4th of May and the 30th of June. There have been 6 Chair's actions approved under Chair's action, which is yourself, the Chief Executive, and 2 independent members supporting a decision that is required. And those are outlined within the paperwork and require ratification by the board today. There are also outlined 4 instances when the common seal of the organisation has been required to be used on legal documentation during the 4th of May and 30th of June period. But these are here for the board to note the use of the seal as required by standing orders. So I didn't intend to say much more than that, Chair, but it's the Chair's action that required the ratification of the board today, please.
Thank you, Richard. Are members happy to ratify the Chair's actions, or do you want to ask any questions about them? No? So those are ratified and we note the sealed documents. Okay.
Thank you, Chair.
Thank you. The Chair's report, well, very short is all I can say. Most of the actions that I've taken have been modified because of COVID, and we have continued to have Chair and Chief Executive meetings with the Minister and the Director General at very frequent intervals to update him on what is happening in our organisations and to be apprised of his concerns and the issues that are being raised with him, and they have been quite successful to date. I have held chairs meetings every 2 weeks to gather good practice and again to assess the state of readiness in many of the organisations in terms of their Q2 and their Q1 plans and their COVID plans, and have continued with my bilateral meetings with independent members and general meetings with the group of independent members so that we can keep apprised of the decisions that are being taken and the action that we need to take for the future so that we start in recovery and reset to look ahead to the next 6 months. We are, of course, extremely grateful with the actions that have been taken within this organisation to lead us through the pandemic itself and the consequences of the pandemic and the hard work that has gone into resetting the services as far as that is possible. And so we're very grateful once again to the executives and all our staff for their amazing efforts during this extremely difficult and unprecedented time. Are there any questions to me? No, thank you. Could we then go on to the operational plan for Q2, Nicola?
Yeah, thanks, Chair. So I'm pleased to present the Q2 operational plan for the Health Board. This has been submitted to Welsh Government on the 3rd of July in draft pending approval of the plan today. The plan was put together in response to the Q2 operational planning framework set out by Welsh Government, which aligned quite well to what we set out as our phase 2 of the COVID response, which we titled the Adapt and Sustain phase. This quarterly planning cycle with Welsh Government is currently replacing the IMTP process that has been temporarily paused. And this Q2 plan particularly focuses on how we re-establish services cautiously alongside making sure we can respond to COVID in particular, and then also maintaining our essential services. It also describes the work that we need to do in particular around the next phase in preparation for winter. So what I thought I would do is if I just broadly run through the structure of the plan section by section, and I'll just draw out some key points, appreciating you will have read the plan in detail in advance. So in terms of section 2, this basically just reinforces how we as an organisation have prepared and responded for the pandemic, and some of those structures that we put in place and continue to use just through different frequencies, both within the Health Board and also as a Gwent region with our partners, which continues through the strategic auditing group on a weekly basis. It also sets out some of this extensive amount of work that we've done around testing and now the Test, Trace, Protect service as well. There's been a significant undertaking where, working again with our partners, we have set up the system and we'll continue to roll that out and use that in the coming period. I think it's fair to say these are new challenges, new services, and I know everybody has really stepped up to the mark to ensure that we meet the expectations that was expected of us. And again, the continued antigen testing around testing for positive patients, as well as the antibody testing, which is also being rolled out now as well. We also felt it was worth highlighting the significant role of infection prevention and control and the continued work that goes on there in terms of advising us around environmental risk assessments, and when we're trying to re-establish services to ensure that we meet the guidance and are providing the best protection we can to our patients and our staff. Section 3 goes into the demand and capacity planning, particularly around our acute services. And the demand side of things, again, trying to make our best assessment of what we feel is the most likely case to enable us to carve out the right amount of capacity for confirmed and suspected COVID cases as we go through Q2. Again, it's a really complex judgment, but we have looked at all of the evidence that's out there and our best assessment, and have identified that we will almost ring-fence 200 beds across our sites for confirmed and suspected COVID, and we're expecting 17 ITU cases that could potentially be needed. Alongside this, and in the operational planning framework, Welsh Government advised us on ensuring that we had surge plan capacity of just under 1,000 beds and up to 70 ITU beds, and we've made sure that we've got surge capacity plans that would enable us to go up to those levels in the event that we needed to. I think alongside that then we've set out what capacity we think we need for non-emergency, non-COVID emergencies. So these are and we have seen those levels of activity come back up to normal levels, despite the fact we've seen a significant reduction in those in the early part of the pandemic. These are now back up to normal levels, and we've needed to make sure that we've got the right capacity in the right areas of the hospital to meet those needs. And it also sets out what our best assessment of what we think we will need for elective care, so that we've got an overall bed kind of plan for the organisation. And on page 25 of the actual plan, there's a fairly simple diagram which just sets out the 200 COVID beds, 950 for non-COVID emergency, 50 elective. And the guidance from Welsh Government suggests we work on an 80% occupancy. So that identifies the value of those beds and what is left unallocated at this stage. It also shows underneath what we've then got as our next surge capacity, which would be doubling up in rooms at YYF and YAB and expansion at Royal Gwent and Neville Hall. We're continuously reviewing those plans in line of changing guidance around social distancing, and we are in the process of testing those again once more now around our surge plans. But that is without using the Grange capacity, which is also there by around 400 beds, which we are trying to avoid using until assuming that we open early in November. But our surge plans will change then when we get into Q3 and Q4. It's important to emphasise this is our Q2 plan. It also sets out critical care in terms of what we would use there and some of our trigger points of when we would start to enact some of those surge capacity plans. It also describes in a bit more detail about the Grange University Hospital, but I'm not going to go into that at this point because we've done that in a lot of detail previously. Section 4, this is talking about essential services, just to reinforce how we are managing to deliver these essential services. And these are set out in a lot of detail. I thought I would just draw out the one red area, which was around ophthalmology, and a huge amount of work is going on in this service to ensure that we can meet the most urgent R1 category patients that have got the greatest risk. And also the significant amount of work that is being undertaken around cancer services and ensuring that we can meet the targets and the access times to diagnostics and treatments along that pathway. And Q2 particularly is focusing on how we increase the capacity for cancer services during the next quarter. But we have done particularly well when we've done quite a lot of work around what we have achieved to date, and we have seen improvements in our access to diagnostics on this pathway during the pandemic for those high-risk patients. Section 5 sets out more around how we intend to re-establish some of our routine services. You know, we are really keen to enable us to restart in a number of these areas, but we need to do so cautiously and appropriately along with the advice. But this sets out 4 clear objectives alongside some key principles, breaking down into outpatients, diagnostics and then inpatient services. And it sets out a lot of the detail that we've been undertaking in order to look at how we re-establish those services. Section 6 has a much greater focus around our primary care and community services and how we are looking to increase our provision and restart some of those services, both across GPs, pharmacy, optometry and dental services. And a huge amount of detail in there where we are working things through and planning to increase that provision throughout Q2 where we safely can. Section 6 talks about social care resilience, sets out some of the work of the community care service cell and our continued approach to testing across care homes to ensure that we protect patients and staff in these kind of closed setting areas. Section 8 sets out some of our plans around winter and recognising the significant work that we now need to undertake. Now Q2 plan is in terms of setting out our plans for Q3 and Q4. It particularly focuses on things such as vaccinations for flu that we particularly will focus on, and how we do our best around diabetes care, areas where we've learned through this disease that having good, making sure we are as proactive as possible to enable us to get through the winter. And obviously we've already talked about the Grange University Hospital and how our capacity plans will need to change as part of that, and we are planning as an executive team to hold some dedicated sessions throughout July and August to make sure we develop this in a lot more detail. The following 3 sections, digital, workforce and finance, are all key enablers to the plan. We've done a significant amount of work on digital. There's increasing demand on the digital services as we enter this new phase, and we've done quite a lot of work to look at how we can best respond to the increase in demands and the new ways of working, and make sure we don't lose the opportunities that the last few months has actually created around new ways of working. The workforce, particular focus not just on recruitment, redeployment to ensure we can deliver the capacity plans, but also, as we've talked earlier, around a significant focus on staff wellbeing, and that continues to be a key priority for us going forward. And then finance, as the final, one of the final sections does talk around again, finance's best assessment with a whole range of assumptions, and where we're trying to predict Q2 and the rest of the year is set out in a lot of detail there as well, which is a key part of the plan. And then the final section just discuss risk and the importance of our continued communication with key stakeholders as we go through the remaining months. And I know a key focus for us is around how we make sure we've got good communication with the public as we look to re-establish these services, and they fully understand what and where we will be delivering. So that's a quick resume of the plan. A significant amount of work has gone in by the teams to get us to this point, but hopefully it gives a good overview of where we are as a health board going into Q2.
Thank you, Nicola. That was extremely helpful. There are a number of questions, some of which have been tabled, but some people wish to ask additional. But firstly, can I ask Judith to enlighten us on major trauma, please, to answer them?
Yeah, thank you, Chair. Just to say that in the document under section 4.1 essential services, under the section on general surgery, there is a reference to the major trauma network and major trauma centre at Cardiff, which the launch had been postponed, and there's reference in our operational plan that would have been considered at the Joint Committee of WHSSC yesterday. Just to say it was, and there was agreement at the Joint Committee that the major trauma network and operational commencement of the major trauma centre at Cardiff would go ahead from mid-September. So I just wanted to add that because it is referenced in the document, and there's just a short update on that. So that's just for noting really for board members.
Thank you, Judith. Can I ask Chris, Pippa and Phil to ask their questions, starting with Chris?
Thank you, Chair. My overall comment, obviously, clearly a lot of work's gone into this, and we have had the opportunity in planning a strategic change to look at it. My question relates to a point that Nicola raised towards the end of her presentation, was around new ways of working. And I just wondered how far we'd gone in terms of understanding what we want to do about that. Have we set any performance objectives, and what kind of outcomes are we expecting in those new ways of working? And particularly, are we utilising value-based healthcare principles to re-establish services? And finally, have we assessed the impact on our financial position of doing all that?
Okay, thanks, Chris. I think Sarah wants to come in on this one.
If I start the answer, in terms of the new ways of working, with the limited hospital capacity that we now have, that has accelerated what is the clinical future strategy of how much can we deliver care closer to home outside of the hospital setting. So there has been clinical review of all of the pathways And starting from the point of the GP wanting to make a referral, what are the opportunities for providing advice to the GP, which might be a telephone, might be an exchange of letters, the opportunities for a virtual consultation with the consultant and the patient, which may be able to provide reassurance or may lead to the patient being offered a diagnostic test that then provides the diagnosis quickly, and so that consultants are calling patients into outpatients because they need to be able to examine them, and then if they are calling them into outpatients, they're focused on how can they make that one trip where at all possible. So it's an acceleration of the direction of travel of clinical futures, which the necessity of the reduced capacity has made everybody focus on what we were already trying to do. So that is inherently value-based healthcare, but we in terms of the whole approach.
Yeah, just to make specific response to Chris's question about performance measures, the answer is no, not yet, but we are working through a way of doing that. So the first area we're doing some detailed work on is clearly outpatients, and the outpatients team briefed the execs last week on the progress that's being made broadly in terms of reducing the number of face-to-face consultations and increasing virtual and triage. And in the next 2 weeks, they're bringing back a detailed plan. And from that, we'll be able to assess the sorts of performance measures we might want to put in place around face-to-face versus virtual consultations. But I think we do now need to do that for in different areas as we move forward. So to answer your question specifically, the answer is no, not yet. But we do recognise the need to set a different performance framework in a COVID scenario than we might have traditionally.
Could I make one addition, which an important part of this is a focus on follow-up outpatient appointments, which again has been something strategically we've been working on for some time, and virtual follow-up of patients where that is appropriate, so that the face-to-face capacity can be used for new referrals.
Okay. Pippa?
Apologies, trying to get off mute. I have two questions, and the first one really is around the testing process and how long it's taking tests to be returned, and whether or not that's having any impact on our ability to trace people, whether we think it's having any impact or not, really. So that was a question that that I wanted to raise initially.
Thank you. Mez?
Okay, thank you. Yeah. In terms of turnaround times for sort of tests, in terms of the end-to-end process from taking the test to test return, the latest data on that shows that it can take up to 72 hours for 90% of those tests to be returned from Welsh labs. In terms of the lab process itself, over 90% are processed within 48 sort of hours. We are monitoring the test results and the end-to-end process very closely, and there's work going on nationally to improve the times for turnaround. And in terms of the test and trace process, we are following up all positive cases relating to people who are testing positive. And obviously we recognise the shorter the timescale for turnaround of test, the easier and better that would be, but we're not experiencing any delays with following positive cases through the test track and protect process.
Thank you. If I might ask my second question, it's around A&E attendance, and specifically whether or not I understand that Cardiff are have instituted a telephone triage system, and whether or not we were planning on doing something similar, but also if we were, whether or not we could use people's motivation for attending A&E or there to set a kind of set of performance measures, so we understand why people are attending, and whether or not there is an alternative pathway for them. So a little bit of the narrative, I guess, behind the figures, as well as this, whether we're going to proceed with a similar system ourselves. Thank you.
We should come in and answer that. So yes, we are exploring that, Pippa, in terms of our approach to what we would call phone first. We would only be looking at the non-999 calls, so we would be looking at the patients that don't require an urgent conveyance, although we understand that sometimes within that group there aren't patients who require to attend an ED. One of the drivers there is obviously the capacity, the physical capacity within our emergency departments, particularly the Royal Gwent, which we know is constrained in terms of its size. And, you know, there's a lot of evidence, as was raised on the Cardiff discussion yesterday, about overcrowding in EDs and the impact that that has in terms of safety, but also the stress that it's currently putting our staff under in terms of being able to socially distance patients who are attending ED, who don't come in an ordered way. So we're looking at how we might be able to schedule some of that work. We've got a big opportunity in terms of an Aneurin Bevan, which Cardiff don't have, which is around 111. So we're currently working with the 111 programme team, and we've developed an internal programme team to pick up the structures that would need to be in place within that for that to work. The clear aspects of that are the communication that we would need to have with our population at a time we're already communicating messages with them, so it's a great time for us to do that, and a population that are now used to accessing things in a different way, so half of that cultural change has already been made. The key things for us will be the infrastructure about how we physically would do that in terms of what number does somebody ring and what then happens after that initial call, and then how that marries up with our capacity within the emergency department, which from conversations with Cardiff is the area that they've struggled with a little bit in terms of how they manage that and schedule that demand and still meet patient expectations, as well as coping with a stream of people who will continue to pitch up without having made those calls in the first place. So there's a programme structure around it, and I've just noticed that Pippa's dropped out. There's a programme structure about it. It is complicated, but we are keen to get this in place as soon as we can to mitigate some of the risk and some of the delays that we're currently experiencing.
Thank you, Claire. Are there any further questions on A&E and the management of emergencies? Testing? If not, I'd like to return to testing. There are a couple of questions here, one from Tej, one from Paul. Tej?
Okay, thank you, Chair. My question was around testing in the care sector, and it's been great to see that testing within care homes we've really grasped the nettle on that and offered some really comprehensive support there. I'm just wondering about how systematic testing is happening with the domiciliary care workforce. Clearly it's more straightforward to contain infection within the environment of a care home, potentially. Out in the community there is concern.
Who would like to answer that? Is that yours, Mez?
No, I think Nick. Well, I mean, I'm happy to. We've been obviously offering testing to all domiciliary care agencies and their staff that can be done either through our own drive-through services at Rodney Parade or through the national portal. There's been quite significant take-up in some elements of that, but we're seeing very little in terms of positive returns for domiciliary care workers in terms of them testing positive. And what's been really interesting in the dom care market has, over the last probably 5 to 6 weeks, the market's probably, and the availability of carers is probably the best it's been for 2 or 3 years in terms of the provision that the councils can call on to put in place for patients who want a domiciliary care package in their own home. I think this is probably driven partly by staff coming into the sector, but also we've seen a number of agencies who are able to support more patients because people who have been at home and are supporting their own relatives as well. So I think in terms of the dom care market, it's very robust currently. The testing programme is working fine with them, and we're seeing very little in terms of positive outcomes of tests.
Thank you. That's really helpful to know that the positives are pretty low.
Thank you. Phil.
Yes, thanks, Anne. Just wanted to say I think it's a really comprehensive report. Tells a really good story about where we've been, but I think also demonstrates that we've got a lot of grip in terms of where we go in. So I think there's a great amount of work demonstrated in there, and I think a lot of confidence we should be taking from what's going on, but also what's written in the plan. I've got a concern about the safeguarding numbers. Clearly, safeguarding referrals have drastically reduced throughout the country. So it's a national issue. And of course, generally, when children are referred through the paediatric services, it's generally the more concerning areas of safeguarding. So that's more worrying to think that area of the service is actually not seeing anything like the referrals they were pre-COVID. So I just wondered whether, this has probably already been done, but whether we should be alerting our community services, particularly to this issue, that they need to be probably more vigilant than they've been in the past, particularly because, of course, schools are now not functioning as they were. So that's a huge level of surveillance that has dropped out of the system. So when you think of the services that we've got remaining in the system, I think it might be just worth running it past primary care, for example, to be more vigilant, community nursing staff and people working communities, because I'm sure that with the pressure from families that COVID has resulted, that probably safeguarding issues have not diminished, but they've probably increased. But actually, because of the lack of visibility, they're not coming through the system. That was my major comment and question, really. I was going to ask about domiciliary care, but
shall we deal with safeguarding first, Phil?
All I was going to say about domiciliary care is that I think the question has been answered for the time being, but I think domiciliary care is the area that we will need to watch very closely if we start to get a resurgence. That's all.
Yes. No, I would endorse that. Rhiannon, would you pick up Phil's issue on safeguarding?
Yeah, thank you, Chair. They're really important points, Phil, and just for assurance of the board, this was picked up in the recent safeguarding committee, and this is an area that is high on our safeguarding risk register in terms of as you've identified, the unseen harm. It was also highlighted when we undertook a review of the services for family and therapies, and they're identifying their significant concern in terms of lack of attendance, particularly through the Children's Assessment Unit and ED of children's attendances. And as you highlighted, the lack of schooling and other social activities where perhaps any safeguarding matters might be picked up. So there is a work stream in terms of that enhanced vigilance, surveillance, and we're linking in with various teams, specialties and partners to ensure that is high on the agenda, and probably worth just mentioning the radicalisation agenda as well, because obviously in terms of the situation with safeguarding children, but also domestic violence, the radicalisation agenda is at risk as well in terms of the hidden scenario of remaining at home. So Phil, assurance that we are dealing with it, and it was an agenda at the safeguarding committee.
Thank you, Rhea. Is that okay, Phil? Paul?
I've got one. The question I was about to ask, I think, has been answered, because I think it's an incredibly comprehensive report with regard to reconnection of essential services and other services. So I'll park that question. But the question I wanted to raise was, this pandemic, of course, has been a journey, and we've had national lockdown, and we're now seeing some local lockdowns, and in particular, we're now also seeing some issues of parts of communities in lockdown. In other words, it's clustering within at street level, etc. And I just wondered whether or not this has any implications for Gwent, and if so, is there a plan in place to address it?
Thank you. Mez, could you answer that?
Yes, of course. Yeah, thank you. In terms of the test track protect process, in Wales, in terms of the positive cases that come through to that service, we are able to plot those cases by location, and through monitoring through that system, both at a local, regional and national level in terms of surveillance. We're hoping that by plotting those locations, that would be able to enable us to identify early whether there are any clusters appearing in relation to communities, or whether they're linked to workplaces and so forth. In terms of the plan in place, we have an operational plan at a regional level, and also there's a nationally agreed outbreak control plan in place, which is issued by Welsh Government, and we're all signed up to work to that process. We would be responding at regional level to any clusters initially, and then drawing national support from Public Health Wales to any outbreaks that would occur.
It's clustering, really, this new term that's come out. I just wanted to see whether there's any issues at all that there is in Gwent on this.
Yeah, no issues currently in Tyncads for any clusters. In the last 7 days, we had 7 cases. In terms of where cases occur, we also look at whether they're linked to any closed settings. And support, but we don't have any community clusters currently identified through our track and trace process. Obviously, it does rely as well on public coming forward for testing, so we'll know where our positive cases are occurring, and that's something we need to encourage if anybody has any symptoms to come forward for testing.
Good. That's the questions on COVID. Can I go ask questions on the Grange Hospital then, Anne, if that's all right?
Yes, please.
First of all, have we got a date for the decision by Welsh Government in relation to bringing this matter forward?
Judith here. No, not as yet. As you'll know from the plan, that we've submitted it to Welsh Government as part of our Q2 plan. Welsh Government were expecting us to do that. The plans are currently being reviewed, and clearly there is a process within Welsh Government to look at the financial implications of all the plans that they've received at Q2. So I am expecting a response on our Q2 plan shortly, but as of yet we have no definitive date for that.
Okay, thank you. That's helpful. Second thing is on the arrangements for access in the hospital from all parts of Gwent area. The intersite transport plan seems to be very detailed and thoughtful, and I'm just wondering about the issue of public transport perspective, and whether the board, if we haven't got information as yet, whether the board could receive a report at some point in the near future on how, bearing in mind Gwent's quite a big area, to ensure that the public are aware of the new transport arrangements, public transport that would be available for them to get from their local communities to the hospital and back.
Yes, thank you, Paul. So pre-COVID, we've done a lot of work with the transport providers and Transport for Wales and local authorities around transport arrangements. We had made reasonable progress. All that obviously got suspended as a result of COVID. We have now picked that back up again, and the executive team has requested an update on that. And clearly we can bring that through to the Planning and Strategic Change Committee. So we do recognise it as an important issue, but also the impact of COVID may have impacted on our original plans as well. So we need to do another loop of public transport providers in terms of how COVID might have changed their planning arrangements. And clearly we're also potentially opening the hospital earlier than we had originally anticipated. So we need to have those conversations as well.
Yeah, that was the issue, really. I think that to open a hospital 6 months earlier is one thing, but then in terms of the COVID, etc. So that's really helpful if there's going to be a report available. And then the final question on this particular part is to say congratulations to the team. There's an excellent Facebook Live with a virtual tour of the new hospital, and I want to congratulate those involved. And obviously some very good work on communications with regards to social media. My question is, what about information and support and advice to the public who haven't got access to social media? What's the plan to be able to support and address and provide information to members of the community who haven't got that accessible?
Richard, do you want to come in on that?
I will do. Thanks, thanks, Chair. Thanks, Judith. Thanks, Paul, for your question and for the comments that you've made around the positive work that the teams have been doing on communications. That's very welcome. But we recognise also that we have much more to do in the coming weeks and months. As you will know, we have a communications and engagement work stream and a plan in place, which we're continuing to develop and refine as we move forward. We're also learning from the period of COVID-19 as well thus far in relation to the work that we need to do. We've used extensively social media platforms, but we've also been working with our partners to use their community networks and their well-established networks which reach well into each of their local communities. So going forward, for those who don't use social media, we'll continue to utilise those arrangements extensively and build on those, especially at this time when we can't go into our usual engagement activities across our communities. But we'll also be using more traditional methods such as leaflets, newsletters and information booklets for those who don't use social media. We've agreed, as I've mentioned previously, with the CHC about booklets for households and other information leaflets on specific services. We're just building and launching some new web pages around the restarting of our services and how patients can access information about services as they restart, and that will be web-based at this time, but we'll be looking at how we make sure that that is communicated for those who don't have access to the computer networks, etc. But of course, we'll continue to use traditional media, the press, TV and radio, and already have, as you mentioned, been undertaking a range of work at the Grange, and we had good coverage over recent weeks from the BBC and other national media in relation to the development there at the Grange. But even our local press, we've, before COVID, had a regular South Wales Argus chief executive briefing, for instance, which we'll restart and take other opportunities as they develop. So our plans are multi-stranded. We will continue to focus on all of these, not just exclusively social media, to keep that regular rhythm, really, of information and communication on a range of services and aspects of clinical futures, which we recognise really will need to be accelerated even further over the coming weeks and months. I hope that helps in terms of your question, Paul.
No, very helpful. Obviously, we can get regular updates, and thank you very much for answering the question. Thank you, Anne. That's one question.
Thank you. Could you just add something to?
Yes, thank you. I just wanted to say the other thing that obviously we absolutely recognise is that 85% of our staff live in our health board area. So making sure our communications with staff are strong and effective will ensure that they pass on that information to their family and friends as well. And we do know from social media that a lot of our staff are posting, correcting things that people might say, or actually giving some really useful personal insights in terms of their services and their departments, which I think is really great to see. So making sure that we can keep communicating well with our staff is absolutely as important as communicating externally as well.
Thank you, Judith.
Just to say that, I mean, staff are excellent ambassadors of the organisation, so therefore, and if they've got a sort of plan on a page of key information and data, then that would ensure that they've fully understood exactly what the situation is, because it's in writing. So just a thought, really.
Thank you, Paul. I think, Tees, you wanted to make a comment on social media?
Yeah, just a quick one. Thank you, Chair. Just to endorse what Paul said about the positive experience of the Facebook Live sessions, all of them, I've watched all of them. The feedback that I'm getting from the community is that there's quite a proportion of people who now engage in communications from the health board that didn't before using the traditional models we were using. And we had looked pre-COVID at how we could expand our engagement methods to get to those people who wouldn't necessarily come across or come to a meeting that we would put on. And I think this is just an example of some learning from this period that we've come through, that we really need to continue and use a multi-channel approach.
Thank you, that's helpful. Now there are a number of submitted questions, so I'll just ask Tish to start, please, with your question.
Thank you. I wanted to ask Chair about flu immunisation. Clearly, we're in our second phase, but we are preparing for the winter phase and immunisation for flu. I just wanted any insight on from Australia on the design of the vaccine, and also if there's any early indications about what is being done to ensure supply.
Liz?
Okay, yeah, thank you, Siege. In terms of globally where influenza activity is at, in terms of the current knowledge towards the end of June from the WHO is that flu activity is reporting globally currently at lower levels than expected for this time of year. So, however, there needs to be sort of caution around that because obviously with the ongoing pandemic, this might have influenced sort of health-seeking behaviours of individuals as well as testing regimes and so on. And also there's also the factor that currently in terms of social distancing measures and obviously promoting of hygiene with hand washing, etc. And these measures might also play a part in mitigating sort of transmission. But also in terms of planning for the autumn for us is very important because we need to protect individuals who could be at risk of co-infection with flu and sort of COVID-19, and planning is already underway in the health board to maximise uptake and to promote uptake of the vaccine. In terms of vaccine availability, no currently indications at all from flu vaccine manufacturers of any issues relating to children's or adults vaccine affecting supply for 2021 winter.
Thank you, Baz. Katie?
Thank you, Chair.
Any further questions, Tish?
Not at this point. I've got questions later on.
Okay. Thank you very much. Are there any further questions from anybody about the Q2 report? If not, are you happy to endorse its adoption? Thank you. And obviously, as the Q2 report and the subsequent quarters report, they are temporarily replacing the IMTP. We will obviously receive a monthly update on the progress that we're making against projections, because it's important for us to keep a track on this. I think it's a very hard job to produce a Q2 report. Because we are surrounded by uncertainty. So I think that this is a very sensibly, prudently detailed report, which will allow us to try and reset the services and yet maintain the capacity to manage whatever might hit us next. And it's really important that we do encourage people to return safely to our services, as we have had many reports now on the dropout in emergency care and people seeking emergency care. So it's important that this is publicised well. Thank you very much for that. Thank you, Nicola and the team. Might we move to intersite transport, please?
Thank you, Chair. It's Glyn here. Yep. So if I just talk through the paper a little bit, and then happy to take questions. So this paper relates to intersite patient transport. And as the board will be aware, they received a paper at the board meeting on the 30th of June around the opening of the Grange as an acute site in November. One of the key risks that was identified in that paper was the provision of intersite patient transport between our hospital sites. The work that's sort of ongoing around developing the intersite transport model continues. It's already started and will continue, so that actually, should the decision from Welsh Government support opening the Grange in November, we're able to put that model in place for that time. The reason for bringing this paper to the board for formal support at this stage is we do need to formally enter into commissioning the negotiations to actually secure this extra transport provision. So in terms of timescales, now is quite a critical time in order to be able to actually start those formal negotiations. So board members will see from the paper that quite a bit of work has already been undertaken to date around how the additional transport provision would be provided, what would be required, and particularly during what we're describing as this sort of transition period, in order to provide safe, effective patient transport. And this refers to both what we call step-up transfers to the Grange Hospital, but also step-down transfers from the Grange to ELGHs and community hospitals. So a number of options were originally considered. They were appraised, and most of those were discounted as part of doing the detailed work. It's also important to say that alongside the provision of extra patient transport, we've looked at the use of transfer practitioners to actually complement the ambulance crew skills, and also a transport hub with the aim of actually prioritising time critical patients and making sure that there's effective management of patient transfers. The paper then goes on to set out some of the key planning assumptions that we've made, and this includes things like an estimate of the number of patients that we think may require transfers, particularly during that transition period that we've described. And this work was based on a fairly detailed assessment of patient activity, looking at data from last year, and it assumed that some patients will present at an ELGH site but will require higher levels of care, certainly during that transition period. So as the new hospital arrangements settle, it is expected that the number of transfers, and I think particularly the step-up transfers to the Grange, that those should actually significantly reduce. So based on those assumptions, we've asked Welsh Ambulance Service, WAS, to actually model a proposal for the extra transport, including making sure that there's appropriately skilled ambulance crews to deliver that service. Alongside that, we're developing an integrated flow centre and transport hub. So as I said before, that would be key to the effective management of patient flow and transfers between hospital sites. Part of that involves the development of a transfer triage tool, and that will be obviously used to support some of the clinical decision making. We plan to pilot this during sort of probably August, possibly into September, prior to the Grange opening. And what that allows us to do is test some of these key aspects of the model, make sure that they're working properly before the Grange Hospital actually opens. The paper also includes some workforce assumptions. So again, we've already had informal discussions with WAST around additional paramedics, urgent care assistants, and non-emergency patient transport staff. So in terms of some of the recruitment timelines, we're already on working on recruiting staff through the Ambulance Trust by the end of November. Given that the Grange will open during November, there are contingency plans around the use of agency staff and overtime, and we also have the opportunity to use potentially to subcontract additional support through WAST as well. So there's a number of contingencies there around the workforce plans. The paper then talks about some of the key enablers. We've already talked about effective communication and engagement. And yes, it's really important that people understand where they need to go, where they need to present based on different conditions. So it is important that we make sure that effective communication and engagement continues in the run-up to opening the Grange Hospital. There are a number of other key enablers in the paper. I won't go through all of them because I think most of them are fairly self-explanatory. I know that one or two of the questions that were raised by board members were around how do we get assurance that the systems will be in place to respond to transfer requests in a timely way. And I think hopefully what the paper sets out is quite a different model to the one that we've operated before. There is significantly extra transport provision in there, but I think also great to focus on clinician-to-clinician discussions to make sure that patients are safely cared for and transported between hospital sites. Sorry, I can't see the question. Yeah, okay. Just a couple of other areas, and then I'll pick up on some of the questions that are being posed on the message board. One of the other areas that we will be looking at is enhanced performance and contract monitoring. There's currently a weekly set of meetings to discuss the inter-site patient transport, but there will be a formal group established and the development of a performance dashboard that will closely monitor the effective delivery of transport, but also looking at any incidents and concerns that are raised so that we can escalate and deal with those quickly. Financial implications, obviously you'd expect me to cover this off. So the paper sets out the potential revenue costs, some of the setup costs, and also potentially some capital costs if WAST need to invest further in their vehicle replacement as part of this. I think it's very important to say that at this stage, this is very much a financial provision within which the Health Board, ESC and WAST will need to agree the additional costs of delivering this solution. So it's not necessarily about spending up to this amount, but actually trying to operate within it to deliver an effective patient transport solution. Given that we're now working on the assumption that the Grange Hospital will open in November, the revenue costs for the current financial year are estimated to be up to about £2.6 million. So this takes account of the part year effect of implementing the solution, plus the additional setup costs. We've included this in the transitional funding bid that was part of the Grange Hospital paper that the board received back at the end of June. It's also included in the revised month 3 financial forecast that the Health Board has submitted as well. So again, we're conscious that there will be an additional cost to doing this, and we've built in a financial envelope within our current financial plans and projections to allow us to move forward with formal commissioning negotiations. To answer the question around how long is the transition period, initially we're working on the basis of probably a 12-month period. It's hard to quantify it exactly, but I think what we'll also look to do is we will certainly want to review it after 6 months, and that would effectively take us from November through to May. So we will have experienced the opening of the Grange Hospital, and we will have actually operated through a winter period during that time. So I think that will give us some quite good intelligence on which we can evaluate how it's going after 6 months. I'm just trying to, okay. Sorry, I'm just trying to see the other questions.
Lynn, there's a question on contingency from Pippa, which is posted.
Okay, sorry.
Yes, if I could ask Lynn, I actually think the report was very good, and most of my questions were answered before I asked them, which is always really nice to have. And you've covered off some of the contingency around staffing, but the one thing that I wanted to ask about was, do we have a kind of worst case scenario fallback position? What happens if, for example, I don't know, we don't have access to enough vehicles, or so there was just something for me around actually stating how we would cope with that, because the one thing that we don't want is for patient safety to be compromised in any way. And so I just kind of wondered if you could just kind of clear that up for me. Thank you.
Yeah, so I think there are a number of contingency arrangements, and what we've done through some of the modelling and planning assumptions is to recognise that there will be an increase in the number of transfers. I think in terms of the model as it runs forward, we clearly wouldn't want this number of transfers to be taking place on an ongoing basis. It wouldn't be the ideal sort of patient experience. So in terms of contingencies, there are some contingency arrangements around availability of vehicles. So part of the discussions with WHSSC will be around both replacement of the replacement programme, but also the ability to lease additional vehicles if we need to. So there is contingency there. The workforce is the other key factor, and as I said before, I think there is a recruitment plan and timeline, but we know that we've got some options around using agency staff, agency paramedic staff, if we need to. It's probably also worth saying that actually WHSSC are currently recruiting generally in response to the wider sort of emergency ambulance services plan. So I think it's important to recognise that there should be a certain amount of flexibility in their workforce and recruitment plans anyway. So I think we've got reasonable contingency arrangements. Obviously, we're at the stage now where we're looking to get formal approval from the board so that we can actually enter into further negotiations with WHSSC, where we'll work through some of the detail. We will also be piloting some aspects of the model during the next few months as well. So that allows us to actually test some of the model before it actually goes fully live in November.
I think Rhiannon and Sarah would like to make an additional comment in response to the question.
Thanks very much, Chair. Hi, it's Rhiannon. I probably just wanted to pick up in terms of the different approach that we're having for this inter-site transfer model that we've had in existence currently. So the importance of the triage transfer tool, we will have clinician-to-clinician discussions between the ED department or the transferring practitioner and WHSSC colleagues. That's something that's not in existence currently, so it's almost like an override position in terms of really discussing the clinical priority for the patient transfer, so that's I'd suggest that's a contingency arrangement because it's different to how we currently operate. So that's important in terms of patient safety. I think the other element is the executive to executive discussions. Again, we haven't really been strong on that previously, but the clinical executives, both from WHSSC and the Health Board, have met and will continue to meet as we lead up to the Grange early opening once we have a final decision on that. And then the final point is strengthened commissioning arrangements. So we've actually set in place clear metrics which will be regularly reviewed to monitor the performance of the new model, which is important. Thank you.
Thank you, Rhys. Sarah?
I was going to make the same point about the importance of the triage tool so that the clinician conversation is using the same prioritisation. And the only addition I would make is that the flow centre will have sight of the entire stack of patients waiting for ambulances, and therefore that clinician conversation can prioritise that whole group of patients, so that that patient safety isn't compromised.
Thank you. And Phil has asked whether or not the clinicians are happy with the 60-minute response time for level 3 transfers.
So the transfer triage tool has been agreed by our clinicians, and the definitions of priority are within that tool.
Thank you. Thanks for the clarification.
Could I ask a question? Could I ask a question with regards to the patient voice input? Obviously, all decisions about where the patient should be are clinically made because that's more appropriate for the patient to be there. But the patient voice about communicating his or her needs to the family concerned. So, for example, the person will arrive at the hospital. There will be a decision made on best place, setting, etc. And it's the patient voice bit about where he or she may next need to be and how that is going to be communicated to the family or friends, whoever's supporting that particular patient. And I wonder if there's any work being done or may be done, maybe with the Community Health Council, etc., with regard to that particular issue on information and communication at the point of arrival at the hospital and what may happen next.
Yeah, thanks very much, Paul. It's Rhiannon. I think that's an important point. It'll be picked up through our whole approach to communication engagement with the public, as referenced earlier. But I think the engagement with the Community Health Council is key. It happens now. So whilst we've got a new model in terms of a new hospital, those discussions happen now. So the patient will be placed in the right environment for those based on the clinical prioritisation, and that communication won't be any different with the new model because it happens currently.
And the new model has a strengthened approach to that initial conversation about what the patient and family want for themselves and what the appropriate treatment plan is for them. And that's built into this new model. We already do it, but it will be strengthened.
Oh, that's excellent. Thank you for that.
Thank you. Angela, have you anything to add to that?
No, nothing to add from me. We work closely with the health board on this anyway, so we'll continue to do so.
Oh, thank you for that. Judith, I think you wanted to update us on what happened at the ESC meeting yesterday. Please.
Yes, thank you. Yeah, thank you. So throughout this work, clearly the Health Board's been working not only with the Welsh Ambulance Services Trust, but also the Emergency Ambulance Services Commissioner. And there was a committee meeting yesterday, so just to feed back a couple of points, because clearly the timely movement of patients around the health system, health and care system, is not just an issue for this health board because we're opening a new hospital, but as services become reconfigured across Wales, something that everybody is turning their attention to. So just two comments to feedback. One was a comment from the Ambulance Services Commissioner to say that they're really interested in keeping close to the work that we're doing in Aneurin Bevan with WAST on this, because they see that some aspects of it, particularly things like the triage transfer tool, might have broader application across Wales. So they're very interested in keeping alongside us on that, which is really positive. And then also a comment from the Chief Executive of the Welsh Ambulance Services Trust to say that that he thought that we had, between us, got to a really positive place in terms of the new model and direction of travel, and making positive comments about the work that had been done, both by Glyn and the team, but also the clinical leads and clinical execs as well. So just wanted to add that to the conversation.
Thank you, Judith. That's helpful. Are there any further questions on this matter to Glyn? If not, this is a really vital part of the Clinical Futures proposals, and we have discussed the development of these proposals on many occasions. We are being asked today for agreement to formal commissioning discussions being undertaken with the Welsh Ambulance Service via the Emergency Ambulance Services Commissioner. and I should be grateful if you could advise me whether or not you're happy to provide that endorsement.
Very happy.
Yep. Thank you very much, and thank you for the hard work on that. This is critical, and we look forward to seeing the performance reports when they're available and the scheme is in being. It's really important to provide the necessary and vital support to our patients and their relatives to ensure that they do get to the right place very swiftly indeed. So thank you very much for that. Could we move on then to the energy strategy? I think Claire's going to present this with Matthew Lane. Welcome, who's the Energy and Carbon Manager. Thank you, Claire.
Thank you. Apologies for the strange camera angle, but we're trying to socially distance and both get in. So thank you very much, Bordar. Thank you for the opportunity to come and present the energy strategy today. As Anne mentioned, Matthew is with me, and I'm extremely grateful to Matthew, Gareth Hughes, the Director of Facilities and Estates, and also Neil Pearce, the General Manager for that service, for pulling this work together, which I think is a great plan for us as a health board. So the plan that we're presenting today, it builds on our track record of previous successes as a health board in terms of reducing reducing energy consumption and carbon emissions. And as with the direction of travel for the wider health board programme of work, we've decided to describe this, our ambition, in the form of a strategy to take us through to 2024. And you should recognise what has really sort of become our house style now around the presentation of our strategies, which I think is really helpful in terms of presenting our plan going forward. The drivers are really well rehearsed for the importance of this strategy, and they're shown on slides 3 and 4 of the strategy itself, and really are very much driven by the environmental and social drivers, which acknowledge our responsibility to our population, particularly given our responsibilities for health and well-being, but also our contribution as an employer with the significant volume of staff that we employ, the fleet and the buildings that we own. The financial drivers in terms of the contribution that energy and water make to our financial envelope, and the opportunities that we have there around forecasting and planning to mitigate some of that. The very clear regulatory drivers, which we'll be aware of and are very well described in the strategy, and obviously our reputational drivers and the social responsibilities that we have given the role that we play within the community. So Matthew has described this quite succinctly in the paper and the presentation that is attached, and he's just going to outline some of the key areas within the points, assuming that everybody's had the opportunity to read it. So he'll look at the context, and particularly about where we are now and where we've come from as an organisation, which is quite impressive, but we know we've got more to go at. How it links to our overarching estate strategy, and really the key themes and objectives that will be important for us, and how we'll track our progress. So, and then at the end, we'll have the opportunity to ask some questions. So I'll hand over to Matthew.
Thank you,
Claire. Good morning, Bordar, everyone. Hopefully sitting socially distant where the microphone is still picking me up okay.
Yeah.
Yeah, I just really wanted to sort of briefly sort of go over the strategy report as it is and try and draw out some of the salient points for you all. So this is sort of strategy that's evolved really from in its present form from 2019, and it'll set out the main areas of focus really for energy and water management going forward, goals and objectives. It will also provide a mechanism for governance and reporting, and also will align itself with other strategies, as you know, the estate strategy, agile working strategy, and the clinical futures programme going forwards. So as Claire mentioned, there are several very key drivers with this. Regulatory is one of the larger areas of this. There's several pieces of legislation coming from national and UK government around reduction in carbon emissions. Welsh Government has set a target, or UK Government has set a target rather of an 80% reduction in carbon emissions by 2050. Welsh Government has sort of brought that a little bit closer with some interim targets in their low carbon Wales strategy, with an aspiration for Welsh public sector buildings to be carbon neutral by 2030. The Wellbeing of Future Generations Act is key in taking this strategy forward as well. We're looking at obviously our inclusion, our collaboration work with the 5 public service boards, and also looking at the 5 ways of working in a little bit more depth within the strategy that I'll mention again in a minute. But in terms of context, where we've come from and where we need to go, we've had some really positive work undertaken in the last years in terms of reducing carbon emissions and energy consumption. We've reduced our energy consumption by, carbon emissions rather, by 33% since 2015 through a reduction in electricity consumption and gas in that period. Last year, again, that will be reflected in our annual report this year, we'll be reporting further reductions in our utility consumptions. And year to date, the first 3 months of this year, we've seen some more reductions in our energy and carbon emissions also, which is positive. So the energy strategy itself, the strategic direction that it needs to follow is to synchronise itself with some other key strategies, that one of those being the estate strategy. So through that strategy, there's an objective to try and reduce any unoccupied space that we have or any underutilised estate, which has a knock-on effect to energy consumption. Backlog maintenance and things like that as well, trying to improve some of our less efficient equipment will have an effect. And obviously the disposal of sort of poor quality or redundant buildings will have a positive effect. Aligned to this, I suppose I need to mention is that we're at very early stages with the All Wales NHS carbon strategy, working collaboratively with Welsh Government Energy Service and shared services partners. Wellbeing of Future Generations Act, like I mentioned, I say we have the 5 ways of working that we'll be working to within the strategy. That then will go hand in hand with trying to assist with some of the wellbeing goals, namely the Prosperous Wales and a globally responsible Wales. And we have our own wellbeing objective, as you know, which deals with environmental management, a sustainable approach to building programs, waste management, and trying to reduce our environmental impact. So the aim of the strategy really, or the core of the strategy, sits with 4 main themes: data management, emissions reduction, culture change, and lastly investment. So data management then, a lot of our estate, 95% plus of our estate now, we have the joy of smart meters. We also have our own monitoring and targeting software and various online platforms that we need to enhance our analytical capability through. So that's a big driver for us. Emissions reduction, of course, knowing the buildings that we've got, identifying opportunities, publicly displaying the operational efficiency of some of these buildings through the display certificates, and then working towards then programme of investment in some of the identified projects. But lastly, a big key theme for this is engagement with our 14,000 plus staff, so we can all do our little bit to help on this matter. So yeah, the 4 key themes there that evolve themselves into sort of 12 key objectives, broadly dealt quite nicely at an organisational level, a divisional level, and sort of our local team level as well. The big one, I suppose, organisationally, is that we commit to our continued 3% reduction in carbon emissions year on year, and demonstrate our commitment to neutral 2030 aspiration that Welsh Government have. We've got our divisional objectives around reporting and utilising funding efficiently and appropriately, and some team objectives a little bit more day-to-day around project identification, working up business cases, financial forecasting, and this sort of thing. So I want to touch upon briefly the sort of governance and monitoring of this. We've identified a governance structure through the Facilities Management Board up to the Wellbeing and Future Generations Programme Board, Public Partnerships and Wellbeing Committee, and finally, obviously, Health Board. We've got a number of sort of statutory mandatory reporting requirements that we need to adhere to, and we'll continue to do so. Monitoring and review, we're monthly tracking our 3% target, and we also get audited annually separately on our energy use and activities through our ISO 14001 programme. Investment and funding, just want to lastly touch upon, there obviously for some of the larger schemes that we may need to look at in the future, we might need to be quite innovative in certain in the funding streams that we try to utilise, whether it's our own capital or whether it's things like the Welsh Government refit scheme, any shared savings mechanisms that may be available to us. So in terms of, I suppose, in terms of risk for the Health Board, if we don't sort of continue to undertake the activities that we're doing in terms of reducing our energy consumption. Energy consumption obviously has a cost, and we're very exposed to the volatile global commodity markets. There's also a risk that we don't meet our obligations with the Wellbeing and Future Generations Act, or demonstrating our commitment to Welsh Government aspirations. There's also the risk of increased carbon emissions, of course, and obviously we may be penalised in any future legislation that comes forward that has carbon in its body. In terms of funding bids, we also may be penalised if we're not demonstrating emissions reductions in things that we do, but the strategy is intended to be very much a live document, and the appendices at the back evolving to sort of update new projects that come on board. But there'll be a series of sort of other sort of programs behind that, I suppose, to monitor and manage progress of those. So in terms of what we're looking for from the board today, I suppose, is A, to approve the strategy and to continue to make some good progress in this field, but also to request that we get sort of ongoing support, really, to help with the implementation of it. Thank you.
Thank you, Matthew. That was very helpful and clear. We have a number of questions. Shelley?
Right, sorry, I was just unmuting. Yeah, no, I think that's a really excellent piece of work, and thank you very much. And it's easy to read, and I just think it was great. My one question was around just this obviously focuses very much on energy in terms of buildings and buildings use, but we, and as Claire mentioned, you know, you've got a fleet. I don't know what the mix of that is, but I wondered where that piece of work would be being dealt with in terms of moving to greener types of vehicles, for example, electric. And also another point, and you do make it in the report, talking about communication to staff about how important it is in terms of energy reduction. And I wondered whether or not there were plans in place to put, for example, electric charging in any of our hospital sites or whatever to support that. And I do recall some time ago there was a cycle to work or bring your bike to work or type of scheme in place, which I know at one stage it was finished. But I just wondered if things like that have been looked at. And I accept that might not be chair for this meeting, but I'm not sure where else it would be being dealt with.
Yeah, as far as I'm aware, in terms of sort of greening of the fleet, where there's a sustainable travel strategy being developed, which will incorporate things like that. We're looking at, with colleagues I'm not directly involved with, but I'm aware that we're looking at sort of feasibility for electric vehicle charging across some key sites across the estate. And in terms of the cycle to work scheme you mentioned, I think we may be in very early discussions with sort of revamping a similar type scheme to that. But say I'm not indirectly involved with that. Yeah, that's my understanding of the situation with those, Shelley.
Yeah, right. Would you like to?
Just in terms of that, whilst it's absolutely it's a slightly separate piece of work, but obviously very much overlaps, we can give you a briefing outside around the sustainable travel plan, if that's helpful. We'll give a little bit more detail around our plan in terms of our green fleet plans, but also some of our plans which are intrinsically linked with the Grange, but we also need to roll out to our other sites around charging points. So we can circulate that separately.
I have Chris.
Sorry, Chair, could I?
Who's that?
Chair's Geraint.
Okay, right. Sorry.
Sorry, Chair. I thought you asked me to comment on the cycle scheme. Just to confirm, I have been in discussions with Tige and Pippa around the cycle to work scheme. So we've already got a working group looking at that, and we are looking to reintroduce the scheme or a similar scheme to what we had previously, and that will be done under the auspices of the Gwent Travel Charter. So just to confirm that.
Thank you very much, Geraint. Chris?
Thank you, Chair. Thank you to Claire and Matthew. I agree with Shelley. It's an excellent report, a good story being told, and a good strategy to take us forward. The papers do refer to agile working, and I just wondered what impact the agile working that we've introduced or started to introduce and are probably planning to introduce will have on the wider estates policy and our energy strategy.
Can I pick that up? Can I pick that up initially, Chair?
Yes, sir. Geraint.
Yeah. So thanks, Chris. I think the position is that we've just completed an agile working survey, a pilot within our corporate services areas to look at the impact of agile working. We've had some very positive results and feedback, not only in terms of people being wanting to use agile ways of working, but also the impact it's had on their well-being. So what we're planning to do is extend that survey across the health board and to use the findings to inform the estates component of the agile working program that we've got. So we've got a program looking at the estates element of agile working, and one of the first priorities is to look at how agile working can actually impact on the use of the estate.
Thank you for that. Do we know the time scale over which you'll be doing that?
So we've set two timeframes. One is sort of a short-term timeframe, which is by September. So that piece of work will certainly be caught up within that timeframe.
Thank you. Could I ask Louise for her question?
Yes, thank you, Chair. Yes, mine was more around the older estates. I know you alluded to it, but just a little bit more clarity around how we're going to manage our older estate and how we're going to currently be able to deliver an energy saving sort of cost as regards to these areas, because some of them are very difficult to maintain and also very are not able to be adapted to new ways of using good energy uses. Thank you.
Yeah, I think with that point, I think this is where there's a couple of things that come together in terms of the estate strategy and sort of agile working as to whether we actually retain some of the older premises. Then there's a certain amount that we could do in terms of improving the building services and the structure of the buildings themselves. But in targeting that, obviously there's an economic payback, there's a carbon payback that we'll need to sort of investigate as well. but through the estate strategy as well as it is the objectives of trying to reduce the amount of older and inefficient estate that we have. So I think as time goes on to the sort of short, medium, long term, is that we should find that we're moving away from some of the older estate and concentrating our activity in the newer parts of the health.
Thank you, Matt. Paul?
Yes, I think I think it's a very detailed and thoughtful, comprehensive report, which is really good. I think probably it would be helpful in 6 months' time if we had an update in relation to things like the travel and transport and agile working sort of aspect of it. So we've got a holistic picture of what's in the report, which we noted obviously clearly evident, but also some of these additional things which I think will be relevant for sustainability and carbon footprint.
Yeah, we'd be very happy to do that. We'd be very happy to do that, Paul. Maybe as a three-part presentation. This, agile, and our fleet. Yeah.
And transport, travel and transport. That's wonderful. Thank you ever so much.
Thank you. Did you want to make a comment, Emrys?
Sorry, I know. It's just to add to the debate. Really, is that the service model delivery going forward is what should influence our agile working and obviously the use of estate, and obviously to influence that should then influence the energy responses that are required going forward. And similarly, most importantly, we've got to do that with our partner agencies as well, because there will be a lot of joint working and use of common use buildings as well.
Thank you, Emrys. Are there any further questions or comments?
Yes, please.
Sorry.
Yes, please. Could I ask if, when we have the report, that we have a financial sort of overview as to regards to the energy cost savings to keeping the older buildings still alive and in use? Can we have a comparison if that work hasn't already been done, please?
Yes, definitely, Louise. That forms part of our financial planning within the Estates and Facilities IMTP. But when we do a review and an update on progress against this strategy, we'll identify the key deliverables, particularly looking at the risks and the opportunities that we have with that old estate and how that links to agile. So we'll definitely do that.
Okay, thank you very much.
Okay. Are there any further comments? Well, thank you very much for all the hard work in developing this energy strategy. It's really important that we rigorously implement such policies. And of course, we must be absolutely scrupulous in reviewing the estate strategy as a consequence of that, and given our changed circumstances. So as a board, are you happy to approve the energy strategy? And we look forward to seeing further implementation reports on it and some more flesh put on the bones. Thank you.
Thank you very much.
Thank you. Can we pass to the risk report, Judith?
Yes, thank you. Thank you, Chair. Risk report here for the attention of board members. The background on page 2 just reminds the board that the strategic risks referenced in the report are identified through a number of meetings and processes, not least the board committee's executive team, but also issues that are escalated through the organisation, particularly the impact on the implementation of our stated plan and objectives. The risk register also reflects some of the COVID risks that are being managed through the strategic coordinating group that the executive team has set up to oversee the organisation's COVID response. So that's reflected in the strategic risks also. Just before we touch on the risks themselves, just to say in September, we have set up a board session to just review the board assurance framework, risk appetite, and just check that the risk management strategy continues to be fit for purpose and doing what we need it to do. as a board. So board members will see that session drop into their diaries if it's not already gone in. In terms of the risk review itself, this is the risks as at the end of June, identified on page 3 going into page 4. And the only area that has an increased risk score relates to our ability to implement the Welsh Community Care Information System. Board members will recall a special briefing session that was held on this very recently, and also we will be providing regular updates to the board on the progress in relation to the implementation of WCCIS and its impact on service delivery. All the remaining risks, some of the remaining risks have reduced and they're identified. And then on page 4, you'll see a summary table. And I just wanted to assure the board, although the board will know this anyway, based on the conversations that we have, that the executive team are focused on all of those risks in terms of action to mitigate, and they are receiving regular and constant attention. But as you'll know from some of the conversations at the board today, are resulting in changed plans and developments, and hopefully the board feels briefed on all the issues associated with those risks. I think the full risk register did go to the audit committee earlier this week, and also an update on the board assurance framework. So I don't know if Shelley wants to make any comment on that, but other than that, Chair, that's all I wanted to say. Thank you.
Thank you. Shelley, do you want to add anything to that?
Do you want me to mention it now rather than in the assurance?
Please.
Is that okay? Yeah, Judith, you're right. We had our audit committee on Monday this week, and we did receive the board assurance framework and the reworked corporate risk register. And I think we all recognise what good progress had been made since we'd seen it last time, particularly the board assurance framework. But we also recognise that there needed to be more work done. If I can just mention quickly in relation to the board assurance framework, each of the principal risks now have been assessed, particularly regarding the impact of COVID-19. And other further key priority areas have also been added to it. And there'll be a full evaluation report against the BAF to be submitted as planned to the board. I think it's in September, Richard. With the corporate risk register, that's also been reworked. So the copy that we received is in a new format. And there is more information that's been added in on cause and effect, and also the component elements of some of the risks and the mitigation actions arising and their timelines. And that also shows whether they're on or off track by a RAG rating as well, which is obviously linked into the risk assessment. So that's the basis, just to clarify what you've seen here. You've got, if you like, the shortened version here at the board. But what's been agreed, I think, is that the corporate risk register will come 6th monthly to the audit committee, and the risks that relate to individual committees will be fed through in the new format to the individual committees as they meet. And as Judith mentioned, there is a development session to be held sometime in September. And I think that will also follow off, as Judith has said, the risk appetite and the links then between the corporate risk register and the board assessment framework. So yeah, all in all, I think there has been progress, and I think we can just refine and hopefully things will get better and better in terms of our interpretation and understanding as we go forward. Thank you, Chair.
Thank you, Shelley. That was helpful. Has anybody any questions or comments on the risk report? I have a couple of observations, if I might then. Financial balance in 2021 has gone down in terms of risk, and I think that it would be helpful in our board development session to understand why that might be. As we know that COVID has cost us a number of pounds, and we do have the opening of the Grange to consider also. So I think that it would be helpful, Glyn, if there could be an explanation for the drop in risk, if that is how if I've interpreted it correctly. And I also noticed that Brexit is amber. Given the recent decision not to ask for any further extension, I wonder if we could just do a little more work on that, please.
Yes, of course,
Thank you. Okay. If there are no further questions, could we thank you very much for that, and we look forward to our board session. Could we move to the finance report, please?
Okay, thank you, Chair. So board members have got in their board packs the finance report up to the end of May, or month 2 of the financial year. Again, I think because of the sort of reporting timescales that we work to and timelines for our board meetings, it means that was the sort of latest sort of board report that we were able to formally submit to the board. However, you'll appreciate, particularly in the current environment, things move at a pace, and there are a number of things that have happened since then, including that we've now reported the month 3 financial position as well. So what I'd like to do is just update the board on a number of those changes that affect our financial position and our financial forecast for the year, and then just to talk about some of the things that we need to do during the remainder of the year, which I think in part will pick up your point, Chair, about the level of financial risk and how we're rating it. So since the end of May, we've had confirmation from Welsh Government of funding for COVID-related pay costs for the first quarter of the year, which amounts to £8.5 million funding. So that was reflected in our month 3 position, which I'll come on to in a minute. Also, since that time, we submitted workforce and financial plans around the Gwent-wide contact tracing service, which has already started, and we subsequently had confirmation from Welsh Government that there will be funding of £9.6 million to deliver that service, and it's a service that's being delivered between the Health Board and local authority partners, where the Health Board will probably be asked to act effectively as the banker for that funding and for those arrangements. But it is very much a partnership approach in Gwent to delivering that service. You will have already seen and approved or endorsed the quarter 2 operational plan, and that meant that we needed to revise our workforce and financial assumptions as a result of the quarter 2 plans. And at the end of June, we also submitted the request to Welsh Government to open the Grange in November, and again, along with that, is a request for transitional funding of £17.4 million. So in coming up with our financial position and forecast after the first quarter or month 3, we've had to take all of those things into account and at the same time make some assumptions about what we think is going to happen during the remainder of the year. So after quarter 2, so although we haven't been asked to submit operational plans past quarter 2, we have been asked to make financial assumptions and forecasts for the whole of the financial year. So we've had to make some assumptions based on what we know, so best available information. But certainly I think we're in a good position as a health board in that because we've submitted a proposal to open the Grange early, that gives us probably some better planning assumptions than many other organisations. So with all of that in mind, and applying the funding that's actually been provided, particularly for the first quarter, at month 3, our financial deficit is now £6.9 million, and that takes account of the COVID funding that we had for quarter 1. If we hadn't had that funding, it would have been closer to £16 million. And what we've actually seen, if you strip out funding, is probably a small improvement in some of our pay costs, where we've seen some reductions in nurse agency and particularly the use of off-contract agency during June. So that would explain where some of that improvement has come. However, we are still reporting a £6.9 million deficit after 3 months, and that is almost directly related to additional spend that we've incurred as a result of COVID plans. So although we've had funding for some of our additional staffing costs, we've had no funding for some of the non-staffing costs, so things like purchasing beds, equipment, and some of the revenue costs that we incurred in getting the Grange Hospital ready for the end of April as sort of surge capacity. So some of that is still being discussed with Welsh Government around further potential funding. I know Judith mentioned earlier that Welsh Government has got its own internal process where it's scrutinising a lot of these plans in order to secure funding for the COVID pandemic. So if you then roll that forward and take account of all of those things and the plans that we do have in place, we're now actually forecasting a full year deficit for the Health Board of £68 million. Previously, we were only reporting a forecast deficit based on plans or COVID plans up to the end of October, which is where the £41 million deficit figure was previously being reported. So the £68 million takes account of all of those things that I've just mentioned. Clearly, we don't know what the winter period's like. We don't know exactly what resumption of some of the services will mean exactly. So we've had to make some estimates and provisions within that deficit figure. We don't know what Test, Trace and Protect will necessarily bring during the rest of this year. But again, it incorporates the costs of our local testing centres and the contact tracing centre and a level of testing through our own laboratories locally. But as I say, depending on what happens during the remainder of the year, that could increase or decrease. So that's one of the uncertainties that we're trying to sort of deal with. There's a similar picture on capital in that we are still waiting for confirmation of funding around some of the capital bids that we've submitted. So again, you'll see that this is being highlighted as a potential overspend. And whilst we've received confirmation of some COVID-related funding for capital, we're still waiting to hear on a number of bids that we've submitted around capital funding as well. So that's very much the position that we find ourselves in at this stage. Clearly, it will be important that once we get a formal response from Welsh Government around our Q2 operational plan and the associated funding, that we then consider what that means for us in terms of delivering financial balance. And it's very much on that basis that I've assessed the risk around financial balance as I have in the risk report, accepting that there are probably some higher levels of risk that we're running with this year, particularly around savings programmes. What I would say is, interestingly, if you look at our Q1 performance so far this year, our non-delivery of savings for the first quarter was about £5.6 million, but we've actually avoided costs because we haven't been delivering certain services during the COVID pandemic, which are well in excess of that. So whilst I think we do have an ongoing recurrent issue about delivering a high level of savings, at the moment what we're seeing is a significant cost offset that in some ways, if you like, is making up for the savings that we're not delivering at this stage. Now, I think as we go through the year, that situation may well change, particularly as we start to resume services and we look to, in some cases, recover services. It will mean spending more money. And I think that is where, and I think this probably refers back in part to one of Chris's questions earlier, I think it is important that we continue to consider all the available evidence, look at value for money, and consider outcomes when we're making spending decisions as we go through the rest of the year. I think around savings plans, we do need to reframe some of the opportunities that are now available. So we probably need to focus more around things like estates rationalisation. We've just considered a paper on the energy strategy and the opportunities that are available, and whether we can bring forward some of those savings opportunities. Equally, I think areas like agile working and where we use greater use of technology, there will clearly be an impact on the way that we use our estate. Things like travel costs, travel time, and actually some of the admin and clerical roles that are undertaken in the health board. So I think some of that presents an opportunity in looking very differently at how we deliver some of our services, but some of the efficiencies and savings that are available to us. And then the final point really is around value-based healthcare, and I think, as has been mentioned before, it's really important that we take an opportunity to look at how we measure and use outcomes to inform the way that we deliver patient care, particularly where we can provide some of that care more remotely, relying on outcomes information to help us assess risk of harm and deliver those services differently. So I think probably over the next few months, as our plans start to mature and are implemented, it will be important that we come back to the board, certainly in September, with a revised sort of picture, which includes what the financial position looks like for the rest of the year. So I'll pause at that point and take any questions, but hopefully that gives people a useful update on where we are in what is a period of reasonable uncertainty, certainly in terms of the financial picture.
Thank you, Glyn. That was helpful, and thank you very much for the clarification on the risk rating as well. Chris?
Yeah, thank you, Chair, and thank you, Glyn. The latter part of your presentation dealt with the question when I put my hand up, which is about linking it into my earlier question. But just as part of your work to bring something back to the board in September, my question is, how are we going to use the previous work that we've done to identify where we think that the resources and costs are higher in delivering some of the services? How are we going to use that to reset profile the budget that you're proposing to bring back in September?
So this is very much work that we're sort of developing at the moment. So there are some areas where I think it's fair to say it's easier to try and quantify it. And again, I think in the paper we've highlighted some areas where we've seen some service changes, and at this point we would probably find it difficult to quantify what that means in terms of changes in workforce and changes in costs. And I think that is certainly some of the work that we'll be looking to do over the next few weeks up to the end of August to enable us to have a better picture of how much of this translates financially into either cost reductions or reallocating resources in a way that means that we potentially save money in certain areas of our services, but we may need to reinvest some elsewhere. But by doing that, we'll deliver improved outcomes. Some of that we can do through the pathway work. So things like MSK, I think, is really critical this year. And again, that may be a good example of where we may need to invest some money in sort of community-based alternatives, but actually we would then expect to see a financial benefit in some of our hospital-delivered services. And alongside that, making sure that we can then measure the outcomes for patients to be clear that actually we're delivering a better service for them. So it's quite a complicated picture, probably quite a complex question to answer, but we are sort of methodically going through each of the sort of service areas where we know there have been sort of significant changes made, so that we can either assess it as an opportunity or actually identify that some of the changes have happened and therefore we would expect a saving to be delivered and maintained.
Thank you, Glyn. And we shall be having a future board briefing session on value for money amongst our services, so that we can take this further forward at that time as well. Richard Clark.
Yeah, I am unmuted. Okay, a couple of little things from me. One, savings, broken record. I know, you've been in unprecedented circumstances, but there are some things that can be brought forward that haven't really seemed to be brought forward and have been sort of kicking around for a long time. And you mentioned estates and said it could be brought forward now. I think that's something that we really need to grasp the nettle and get on with that, and that will lead on to other things people already mentioned in the energy one. Some of our old buildings, they are just leaking energy like nobody's business. So from a financial saving on the land value itself, you've got the add-ons of energy, etc., etc. And it's really driving home those savings. We put in a lot of papers and a lot of work into identifying them. It's just actually seeing those through and getting those forward. That's the first point. Second point, obviously COVID's given us a new lens of the actual services we provide. I don't want to say turning off the tap, but there you are, I've said it. Are there some taps that we've turned on that the so what question is there has been no detrimental effect on service, the board, etc., etc. Are some of those taps best left off and make savings that way? Do we need to be doing some of the things we were doing in the past that nobody's missed during the COVID period? And the third and final one is on capital. The Welsh Government and national government are making great plays of getting the economy working together and spending vast amount of money on this, that and the other. We have some bids in place. Is this an opportune moment where we have things ready to go, that if there is a capital surge through the Welsh Government, we have projects that we can turn around and say, we can deliver on this quickly and effectively and not take the usual 2 to 3 years to talk it to death? I think the last bit was a bit unfair, I'm sorry, but it snuck out.
Thank you, Richard. Glyn?
Okay, do you want to pick up on the capital one first?
Yes, please.
In reverse order. I mean, in terms of capital, I mean, we don't know. I mean, there's a lot of speculation about whether there will be funding identified to support recovery and what recovery means in the broader sense for society as well as healthcare services. So, as I said, there's a lot of speculation. So it's hard to say whether there is likely to be capital investment, and if so, what that would look like. Certainly, as we face the rest of this year, we know that capital funding is extremely constrained because of all of the things that we've had to do as part of responding to the COVID pandemic. I think your point is absolutely right, Richard, that if there are things that we can do that require capital investment that would lead to service improvements, financial efficiency, then clearly it is important that we have those identified and ready to go as and when we're able to prioritise the capital. And I think for me, probably the energy strategy is a good example of that. It's something that we've done over previous years where when capital has been made available, we've invested in energy efficiency schemes in order to benefit it. But clearly there's more potential in terms of energy in the state. So I'd accept the point that it is important that we have things ready to go if that funding does become available. In terms of COVID and services that have had to sort of be suspended, I think, Sarah, if you want to perhaps comment on that one.
Yes, thank you. I will, as ever, start with prevention, and there's emerging data on things that just didn't happen. So it was in the news today that there's a study from Imperial College that shows that more smokers have given up during lockdown than any time in the last 13 years since the smoking ban came in. I'm waiting on the data for physical activity. My observation would be that more people seem to be physically active. So I think, and the data about physical activity preventing diseases, it gets ever stronger. Also, our own ED data showed that in April we had a drop in attendances for cardiac events and chronic respiratory disease, and there wasn't a corresponding increase in deaths in the community. So, the conclusion is those events didn't happen, and there's a possibility that that might be related to air pollution and, again, change in lifestyle. So I think there's probably things to learn around prevention that had quite a quick impact. And on what I think was the heart of your question, and referrals into services, it's important to distinguish between new referrals and follow-ups. So we would wish to continue to encourage new referrals. I think what we have done is introduce a much faster triage in terms of clinical urgency and a much faster definitive diagnostic test and doing things in our one trip. So I think that is something we would want to continue. The main thing in terms of turning off the tap, I think is emerging, will be follow-up outpatient appointments. I think there is a fundamental question being asked throughout our directorates around who they need to follow up, and if they need to follow them up, whether that can be done virtually. So I think that will be the main area where we do less in the longer term.
Thank you, Sarah. I think, Tish, you had a question about the transformation monies.
Yeah, it was just thank you, Chair. It was just a point of clarification for partners and the public. We have on page 8 of the report, the fourth bullet down, we're talking about the opportunity to divert existing funding to support COVID-19, and that might be to include the Transformation Fund, ICF, and so on. And I think it's just important to clarify that that will be subject to the normal governance arrangements, and that the use of that funding will be entirely in line with the purposes of those funds. So we won't just be diverting that money with wild abandon.
Yeah, thanks for that clarification, Tish. Emrys?
Sorry, I did have a question on continuing healthcare, but I can see it's from 2019-20, not 2021, and that our continuing healthcare costs are starting to come down. So it's not a question I need to ask now.
Okay, fine, thank you. Are there any further questions to Glyn? Okay. Well, we note the report and we look forward to the update and any progress that has been made in securing additional resources would be welcome. Can we now move on to performance? And it's Glyn again.
Okay, thanks, Chair. You've got the report in front of you. Obviously, in terms of reporting performance against performance targets, board members will be aware that since the COVID pandemic, Welsh Government have actually suspended formal reporting and publication of performance against targets until at least September of this year. However, we felt that it was important for the board to have sight of some of the key targets and what things are looking like against those targets. Were we still being held accountable for them? So the paper sets out where we are based on the data that we've got available, so that you will be aware that in some areas, so areas like stroke care, delayed transfers of care, where some of the reporting hasn't formally continued, we've not included those in the paper. In some respects, I wasn't planning to go through each of these individual areas, because I guess what we have done as an executive team and internally within the health board is to look at some of these targets in the context of where do we think there is risk of harm to patients, and how do we take account of that in setting our Q2 operational plan. So a lot of the work behind the operational plan that we discussed earlier was based on an understanding of where people are waiting to access services. I think it also underlines the importance of understanding where we want to change services permanently for the better, but also where we focus more on outcomes for patients, which sometimes doesn't always fit neatly with some of the performance targets, which are a little bit more sort of functional in the way that they look at performance. So I wasn't going to cover anything in particular, but I'm happy to take any questions that there are. I know that David Jones, because he's not here today, had raised a question about clinical coding and the use of robotic processes. In the report, we've identified that we won't actually be doing this work until probably early or sort of later this financial year. Previously, we'd planned to do that work at the end of last year. However, because there was an upfront investment required to do that, and given our financial position at the time last year, so this was a few months before the end of last financial year, we made the decision to defer that and to try and implement it this year, subject to the funding being available. Since that time, we've agreed, and one of the decisions that we made during the COVID pandemic was to actually implement robotic processes, and clinical coding will be one of the areas that we'd look to make those changes. So the original timescale was earlier, but we're now planning to try and do that this financial year. So hopefully that answers David's question. So happy to take the questions.
Thank you. Thank you, Glyn, and thank you for explaining about the importance of concentrating on outcomes and harm rather than more mechanical performance measures, and for the assurance that those areas that are not being reported at the moment, there is still significant scrutiny over to ensure patient safety at all time. I think that's really important. Shelley?
Yes, excuse me, Chair. There was just one query I had in relation to the number of 12-hour breaches, because obviously performance had been extremely good, but it says in the report that there was then a small rise in the number of patients experiencing those delays over 12 hours. I suppose I couldn't quite understand that, bearing in mind that, obviously we have had less people in our hospital system. So, and I know these are not necessarily totally validated data, but I just wondered why we would have had necessarily been having those delays, because obviously there is an impact potentially depending on your age and what have you in some of those circumstances.
Like me to answer that?
Thank you.
Yeah. So yes, you're right. It is an area of concern for us, and it does very much relate to some of the issues that we're having in the emergency departments, particularly at the Royal Gwent, in terms of access to trolley in the first place, in terms of the social distancing requirements, so access to triage, access to first clinician, but also then the ability to get the right patient to the right ward. So one of the conversations that we've been having with the team at Royal Gwent, where this is causing us more problems than in Neville Hall, is around how do they redesign their footprint. So there may be some opportunities in response to COVID to use the first and the second floor at the Royal Gwent. And we've got a paper coming to executive team on Monday, which outlines some of the options to do that, so that our emergency departments and our assessment units may be able to stretch across a bigger footprint, which will therefore give us better processing capacity in terms of the physical capacity to process patients and safely move them on, but also physical capacity in terms of the physical layout of both of those areas. So it has been a real constraint for us. Our ED capacity at the Royal Gwent, when they are very busy and they're what we would describe as full, is normally at about 100 patients. With the social distancing requirements and assessments that we've made at the Royal Gwent, it's tipping out at about 40. So that's a significant impact on our ability to pull patients in, see them, sort them, discharge them, or then move them on to where we need to move them on to, and the same for our assessment units. So we've got some options there which we haven't necessarily had before COVID. I think it is important to notice, though, that non-COVID demand, emergency demand, is almost back where it was before COVID time. So demand is up, and obviously our theoretical capacity is the same, but in terms of our real capacity, it is significantly impacted. But it is something we will track because we know it's linked to quality, particularly some of our frail patients.
Thank you. Thank you.
And can we come in if that's okay?
Yes, certainly, Judith.
Thank you.
Thanks, Chair. Shelley, I think I mean you've recognised the numbers that we're presenting were lower, but I think Claire's picked up on the social distancing, physical distancing elements. But the requirements to segregate are one thing, but actually caring for these patients whilst the staff are in PPE with all the other elements that we need to take into account is taking much longer. So that will be having an impact on transfer time as well. Thanks.
Thank you, Ree. Are there any further questions on the performance report? No? Well, thank you very much. We now move to the key matters from committees. Richard, as my screen has just dropped out, could you go through them one by one and tell me which one's first?
Yes, certainly, Chair. The first reports are from the Audit Committee for Shelley, of the meetings on the 27th of May and 24th of June.
Thank you. Shelley, have you anything to add?
No, Chair, we did meet yesterday, but obviously we'll have an assurance report in September covering those items. So, yeah, I think we've picked up everything here. Thank you. I've got nothing to add.
Thank you. Any questions?
Yeah, can we come in, please?
Yeah.
Thank you, Chair. It's just that I've noticed in terms of the summary report, is page 4 of 10 or 214 of 222. At the bottom of the page, it talks about the theatre's Hughes Surgical Safety Checklist audit. It doesn't actually identify there was a reasonable assurance. I do think that's important to note in the record, just because of the issues that we've had with never events within the theatre environment, and that audit was pretty critical. So just to note, it was reasonable. Thank you.
Thank you, Ree. That's helpful. Any further questions to Shelley? No? Well, what's the next one, Ben?
The next, Chair, is Planning and Strategic Change Committee of the 17th of June, which is your report.
Yes, it is indeed. I don't have anything to add to this, as the vast majority of the issues that we discussed at that meeting have come to a formal board meeting, but I'm happy to answer questions if required.
Very good meeting.
Oh, good. Thank you. Okay. And the next one, Richard?
And the final report in this is the Quality and Patient Safety Committee of the 30th of June, and Emrys as chair for that report.
Yeah. Emrys?
Only one thing to add to the report from my perspective, Anne, is that we are considering a different way of reporting quality for our next meeting, to have a bit more of an outcome-focused reporting.
Good. I'm really pleased to hear that. Thank you. We also have a report from WHSSC.
Oh, you found it. Yeah, great. Yes. Thanks.
Yes.
I've got nothing to add to that, Chair.
Okay. Thank you. It would be nice, I think, and I will take it up with the chair of WHSSC, that some of the issues that they are discussing might be unknown to many of us in health boards, and I think I'll ask her to put a small paragraph in. If they're discussing particular services, what is the service, what are the issues, and therefore we can put in context the types of decisions that are being taken, so that it's much more of a shared understanding. Okay. Right. Okay. Is there anything else? Otherwise, I shall close this meeting and thank you all very much, executives and independent members, for your diligence in producing and reading the papers and coming to the conclusions that you have. And thank you very much. Thank you.
Thank you.
Thank you. Thanks, everybody.
Thank you.